So disclaimer, we don't have a specific COVID heart program. So how it works is that when a patient is diagnosed with COVID and the patient has cardiovascular complications, we follow those patients in a cardiology clinic. And depending on the type of complications that they have during the COVID infection, they will get assigned with the electrophysiology program if they have any types of arrhythmia, or if the patient has some types of, myocarditis, which is an inflammatory process that is caused by the virus or the inflammatory response towards the virus, and it affects the heart. Then these patients, for example, will end up sometimes with some heart failure, and then we'll see those patients in the heart recovery program. Or let's say that the patients sometimes develop cardiovascular complications related to blockage of the arteries of the heart due to thrombosis, so clots that affect the blood flow. Those patients will get seen by the interventional cardiologist. So the virus can affect in different ways the cardiovascular system, and they have different consequences. And based on the type of consequences, then the patient will be seen by this specific cardiologist that specializes in that area.
Okay, that's great. Thanks for clarifying. Are you still seeing patients for heart conditions as a result of COVID?
Yes, and not only that, there's a lot of patients who have cardiac conditions that get infected with COVID. So obviously that presents an extra setback for those patients. And we see commonly now, unfortunately, some of those patients having a pre-existing condition onto COVID complications.
Sorry, you broke up a little bit on me there. Did you say that you're seeing now commonly patients who have pre-existing complications?
So pre-existing cardiovascular problems, let's say someone who had a pre-existing heart failure, pre-existing heart attack, or hypertension, or patients who have comorbidities that predispose them to a worse outcome with COVID.
Okay. Do you know how many patients have been seen to date for heart conditions related to COVID at MCVI?
I don't have the numbers, no.
Okay. Is that something that you think that MCVI would have?
I can ask.
Okay.
I can ask. I would probably have to get back to you, but I don't have the numbers.
Okay. And then what heart conditions have become the most prevalent as a result of COVID?
So some situations. So once the patient gets diagnosed with COVID and the patient gets seen in the hospital, that's obviously a selective group of patients, because again, the majority of the people will not have significant consequences. So what we're seeing is the patients who are in the hospital. Once the patient hits the hospital, we have biomarkers, meaning enzymes, blood tests, where we check and see if there's any damage to the heart. So this is routinely done. So they give a blood test called troponin to see if there's any injury to the heart. Or another biomarker is a proBNP that is telling us about the condition, if the patient is fluid overloaded or if there's a stretch in the chambers of the heart that release this biomarker. And the patient will get an electrocardiogram. That's how we triage the patient. So if the patient has any of these conditions, then we'll most likely are going to request more testing. Some of that testing will require an echocardiogram. So it's an ultrasound of the heart to see how is the contractility, how are the valves. Because remember, this is a virus that is a mainly respiratory virus, but also has effects in the circulation at every single level, and it can affect the heart. So we triage those patients, and if the patient doesn't have any biomarkers or any conditions, then those patients are deemed low risk and they don't require further follow-up. But if for some reason the patient gets decompensated, then we need to start giving them a specific cardiac treatments, like specific medicines to maintain the blood pressure or to keep the blood thin to prevent clots. Some of those patients, when in the hospital, they will recover, and some of them will have a small amount of sequela. Depending on the degree or the severity of the disease in the hospital, they will require further testing. So, for example, if the patient is quite sick and requires an invasive cardiac catheterization to make sure that the arteries of the heart are okay, that will be done immediately. And some patients, we just need to find out if they have any sequela of the infection. And so some of those tests can be done in the outpatient setting as a follow-up, for example, the cardiac MRI, to see if there's any inflammatory process in the heart that makes the heart weak. So there are different levels, and I don't know if I'm answering your question, but it's important to understand that the virus has different degrees of severity. So again, just to simplify how the virus can affect the heart, one, it can cause arrhythmias. It can cause direct injury to the heart muscle, or it can cause decrease in the amount of blood, therefore oxygen to the heart. So in a very simplistic way. And so based on those mechanisms of action, then we tailor the therapy for that patient.
Great. You touched on the sequela of COVID on the heart. Can you talk about some of the long-term effects that you've seen? I think it's a little hard to say, I know, because COVID's only been here for a year almost. But what do you think some of the long-term effects will be if you had to share a prediction, or that you think that you'll see more of in this year?
So something that we have seen related to the pandemic, it wasn't necessarily related to the virus affecting to the heart, but the problem was that a lot of patients were afraid to go into the hospital, so they were delaying care. So we have instances where the patients were ignoring important symptoms like chest pain, and they were not seen on time. So when they get to the hospital, it's usually too late when there's less room for treatment. Some patients will get, for example, they get decompensated with heart failure, but because they are afraid of going into the hospital, they don't get treatment on time. And then sometimes some patients die at home, just not because of the virus, as I said, but because of the pandemic. In terms of the patients that get infected, it depends also on the degree of the infection. Again, a lot of patients will recover without any therapy, but there's some patients that will have significant damage. And it depends also on the type of, for example, the degree of inflammatory response that the body has to the infection. Then we have different sequelas. As I mentioned, one of the most commonly known is the myocarditis, the inflammatory process that affects the heart muscle and makes it weak. But we have seen that some of those patients will recover and with medical therapy. But there are some patients that will get worse and they don't get back to their prior baseline. In terms of, for example, the heart attacks, if you suffer a heart attack while you're having a COVID, then you're going to have a scar and you're going to have damage that is going to be more permanent. in terms of the arrhythmias, for example, those can be controlled with medicines. And once the inflammation is gone, usually those patients might be able to recover fully.
Great, thank you. Let's see. What can patients with COVID-induced heart conditions do to better their heart health?
So it's really important to be in close contact with your provider. So they need to make sure that they take the medicines, they have plenty of supply at home. Don't wait until they're running low in medicines. Make sure that you check your daily weight, you check your blood pressure, your heart rate, and if you have any problems or any changes, you communicate with your provider so they can make adjustments. And again, now with telemedicine, it's very simple, very easy, and you don't have to get out of home, and so you can communicate with your provider. But important is not to change your medicines. At the beginning of the pandemic, there were some concerns about some of the heart medicines that not being as effective with COVID. And after studies have proven that the medicines remain effective, the recommendation is that you should not change your heart failure medicines unless instructed by your provider.
Great, that's a good tip, thanks. And you touched on the ways that they can monitor their heart health from home, so that's great. Are there any other technological innovations, though, that you would like us to note?
So at Baptist, we have a program called Massimo that is a patient that presents with COVID and meets certain criteria, and they don't necessarily need to be admitted to the hospital. They can be monitored remotely with the help of a home health team, and they get released with a special monitor. And if the monitor senses low oxygen level, then the patient is brought back to the hospital for further evaluation and management.
Great. And what was that program called again?
Massimo.
With
double
okay,
S.
Great.
Mm-hmm.
John, did you have any other questions?
Just a quick question, Doctor. I know we did a blog with your help on myocarditis in August, the lingering effects of COVID on the heart muscle. And right back then there was very few studies on myocarditis and COVID. Is anything since, it's been 5 months, I guess, I don't know, that's not a long time in terms of studies, but is anything new related to COVID and myocarditis, inflammation of the heart muscle that we should know about? Or I know you mentioned some can recover relatively soon, others are lingering, have the issue.
Right. I think one of the clinical trials that got the most attention was the German study with the 100 athletes that got scanned with the MRI, and some 2/3 of them were found to have signs of myocarditis related to COVID.
Right.
But after that clinical trial, the other ones are epidemiological studies, but nothing specific in terms of treatment.
Okay.
Nothing has changed in that regard.
Okay, and what would be the top 2 or 3 symptoms of myocarditis to make people aware? Is it chest pain or shortness of breath?
So it's usually similar to 2 different presentations that we commonly have with cardiovascular disease. It's the shortness of breath, chest pain, fatigue, weakness, which are very inspecific, and it can be present in so many other things. And so that's when you really need to go to the hospital, because
Right.
it cannot be diagnosed with just clinical signs or symptoms. You have to get modality testing that is specific.
And the final question, I know we first wrote about the heart failure program in February, almost a year ago, right before the pandemic. And has the program grown substantially in terms of much more people being diagnosed with heart failure? Maybe not necessarily because of COVID, but just in the past year, because maybe more people come to MCBI because they fear they have something, COVID, and it happens to be heart failure. Has there been a substantial increase in the program, the people being monitored?
I think the growth of the program has been significant, not because patients are aware of that, but because we're getting more referrals through, as I mentioned, providers and after discharge from the hospital. Okay. But usually it's not because of the patients are getting more diagnoses. It's just a referral pattern that we're having.
That's it for me. Thank you very much. A lot of great information here. Erin?
Thank you. The other thing to add to that, because John sparked an idea. So while there hasn't been significant growth, it's only been through providers. Since you said that heart failure is going to continue to grow due to the aging population, do you have like an estimation, or how much do you think it'll increase this year, given COVID and all the other factors in play?
So I can give you national numbers. I don't have local numbers, but the heart failure is projected to increase by 46% by 2030. So expecting to have from 6 million going up to 8 million Americans with heart failure.
That's substantial.
Perfect. That's exactly what I was looking for. Thanks. Not a good thing, but what I was looking for.
Yeah, I know. No, that's a substantial increase. Well, I think that's it, huh?
Yeah. David, did you have anything?
No, that was really, really good, comprehensive. So I think that more than covered it. Thank you so much.
Thank you. My pleasure.
Thank you, doctor. Thanks again.
Thank you, doctor.
Thank you, everybody.
Bye.
Take care. Appreciate it.
Thank you.